Morning. Good morning. How is everyone? So I'm Peggy Kendall. I'm the Allergy Division Chief, and I am pleased to introduce our Parker lecture speaker today. And first, I'm going to tell you a little bit about Dr. Charlie Parker, who is near and dear to our hearts. He started this division in the early 1960s, and for a while it was just a couple of people doing research. And then he brought in Dr. Wedner, who was our allergy division chief for many years, but Dr. Wedner trained, and Dr. Kulczycki, one of our other allergists, both trained with Dr. Parker. And he really made a name for this division at that time. And eventually we had Dr. Wedner become our division director here, and he's continued in the tradition of doing our research. And Dr. Kulczycki also has carried the division for a long time. Dr. Parker was really an amazingly productive scientist. He was an immunobiochemist, and he made great contributions to the field of drug allergy. He defined the immunochemistry of penicillin allergy. He developed the first and only valid drug allergy skin test and desensitization procedures. So if you've ever called on us for drug allergy desensitization in the hospital, we now do procedures where we do lots of skin testing for lots of different drugs and lots of desensitization protocols, but they're not validated in the same way that the penicillin one was. And we basically base all of what we do now on these. He helped define the immunology of hapten drug IgE interactions. And as you know, IgE is what causes the life-threatening allergic reactions that we have, or at least the immediately anaphylactic related drug allergy fatalities. He used anti-tumor conjugates for cancer immunotherapy. He used fluorescence quenching to measure antigen antibody interactions, which was novel and is still used today. He expanded the role of the radioimmunoassay in medicine, and I don't have to tell you about all of these components. He also demonstrated that the slow reacting substance of anaphylaxis, just called SRSA at that time, was a metabolite of arachidonic acid. And that later gave rise to the leukotriene inhibitors that we use today for allergy and asthma. So Singulair is an outgrowth many years, decades after this. So he was one of the discoverers of leukotrienes. He demonstrated that the side chain on leukotriene C4 was glutathione, and showed that if the cells were deficient in glutathione, they couldn't make these leukotrienes. So that really gave us a lot of understanding of mast cells. And we really, we need to move forward more on mast cell work. He was really one of the early pioneers of that work, and we need to do more of that. So now I'm going to introduce our speaker for today. Dr. William Lumry is here from Texas. He's a fellow Texan, and he and I have walked many of the same institution hallways, although not his alma mater. Texas A&M, GIGM. I'm from University of Texas, so that was hard to say. And then he went to University of Texas Medical Branch at Galveston for his MD, a place where I also worked at one point. Did his residency here at WashU, which is how we were lucky enough to come to know him over time. And then he did his allergy fellowship at Scripps Clinic and Research Foundation in La Jolla. Interestingly, Dr. Lumry is a heavy hitter in many areas. He went into private practice in Dallas in 1982, so he's been in private practice for 40 years, yet has still been a clinical professor at University of Texas Southwestern Medical School, which is my alma mater. He attends at Parkland Allergy and Asthma Clinic, trains medical students and residents who rotate in his practice. He rose to the ranks there and became a full professor in 2004. He also does a ton of clinical research related to allergic diseases of all kinds, He has 156 publications, including one in March of 2022 in the New England Journal of Medicine, inhibition of prekallikrein for hereditary angioedema. Interestingly, Doximity does reviews of publication numbers from training programs, and WashU hits high in that. And Dr. Lumry was in the group of trainees between 1975 and 1982, and was the second most highly published among those who were in training at that time here. So he's really very prolific and does a lot of things. And we had a very nice dinner last night. He's also very humble and really, really loves his work. So with that, I'm going to turn it over to Dr. Lumry. Welcome.
Great, thank you. Well, thank you, Dr. Kendall. I appreciate it. And thank you all for coming out today on this cold morning. It wasn't this cold in Dallas today. So thank you for walking across the street and being here. As Peggy said, I practice in Dallas. I've been involved in this work with hereditary angioedema really since the late 90s when we started getting therapies for this illness. I trained across the street at Jewish and didn't have an opportunity to know or work with Dr. Parker when I was here in the late 70s. However, his work sort of has followed me around. As Peggy mentioned, I trained at Scripps. My job at Scripps was to give people aspirin and make them have asthma and or urticaria and angioedema. And at the time, we were trying to understand what that slow reacting substance of anaphylaxis was and why at the same time people would react to aspirin or nonsteroidals in the way that they did. And it turns out it's all about arachidonic metabolism and generation of leukotrienes in people that are susceptible for sort of a switch from prostaglandin formation to leukotriene formation, causing an allergic or not really an allergic, a reaction, asthma or urticaria. When I moved to Dallas, Tim Sullivan, who had worked with Dr. Parker here for years, was beginning the allergy division in the early 80s in Dallas, and brought with him his drug research that he had done with Dr. Parker, and drug allergy has been a mainstay of that program down there since then, with Dave Kahn, who's now the president of the Academy of Allergy, sort of leading that effort. So Dr. Parker's had significant impact on sort of what I do and what we all do, I think, in this field. So what I'm going to talk today about is angioedema. We're going to go through, I guess I need to do this piece. So I'm multiply conflicted. I have a lot of work with a lot of different people. I sit on the hereditary angioedema board, advisory board, and but we'll be talking on point today, not talking offline. Hopefully at the end of this morning, those here and on Zoom will be able to differentiate the different types of angioedema simply based on history and understand the pathophysiology and the response to therapies that go along with that, to try to describe the evidence-based approach to the diagnosis of angioedema and then summarize the advantages and disadvantages and frankly, the optimal use of the medications that we have in long-term management. So to start this off, I'm going to give you just a couple of cases. This is grand rounds, so we'll do that. Joe is a 34-year-old male. This is a patient of a good friend of mine, a colleague who was a household professor here in Barnes, Mark Lydell. Now has a hereditary angioedema center in La Jolla. 34-year-old gentleman presents to ED with swollen lips and tongue developing over the last 45 minutes. He reports having mild oral itching and tingling during lunch while he's eating a chicken salad sandwich. This went on to develop cutaneous itching urticaria while driving back to the office. And just as an aside, he had begun lisinopril 5 days before for treatment of his hypertension. He stopped at the ED en route. He's now complaining of belly pain, nausea, facial swelling. While waiting in the triage, he's developed sort of diffuse pruritus and progressive lip swelling. He's brought back and he's noted to have both oropharyngeal and tongue swelling. He's drooling. He's got facial erythema, perioral edema, and on auscultation, his upper and lower airway exam is abnormal. He's wheezing, stridorous, and having difficulty speaking. He's given epinephrine and antihistamines, epinephrine subcutaneously, antihistamines IV, and he's better in 15 minutes. The cutaneous symptoms recur about 40 minutes later. He's then given another dose of epinephrine, which he responds to, and he's discharged 3 hours later in improved condition. He was told to consult an allergist for further evaluation. Any thoughts about what may be going on with this guy? Basal acidopril, okay, that's a good thought. Any other thoughts? You've seen this show before, haven't you? This is Dr. Parker's daughter. She's going to be rooting for the Netherlands on Saturday, so you can do what you will with that. So anyway, he was found to be sensitive to tree nuts at the allergist's office, and they were present in his chicken salad sandwich, and the diagnosis is an allergic angioedema due to tree nut allergy with associated other anaphylaxis symptoms. So our second case is Ellen. She's a 26-year-old female. She presents to your office for a follow-up after a recent hospital visit. She reports that she's had recurring face swelling, throat swelling, and hand swelling. Review of the ED and hospital records, she's had airway episodes treated with antihistamines, prednisone, epinephrine without response, and despite that had progressive respiratory symptoms. She was scoped by the otolaryngologist, and on your right is what he saw, confirmed edema of the epiglottis. She was admitted to the ICU for observation, but not intubated, and discharged after 2 days. She reports having recurring skin swelling about 1 time a month since she was 16, so the last 10 years. She's not had any urticaria or pruritus associated with these episodes. She's had 3 ED visits, and she's been treated and told that she had allergic reactions each time. The episodes are, she's also had episodes of sort of spontaneous, unexplained abdominal pain, which occur every 3 months or so. And every time she's been evaluated for that abdominal pain, everything has been normal, including a normal endoscopy, colonoscopy, abdominal CT. She's not on any medications. So her family history, her mother and grandmother have infrequent skin swelling, but and both were told that they had endometriosis and irritable bowel syndrome. The laboratory that we got, or she was got in the hospital, so CBC is normal, CMP was normal, amylase lipase were normal, gynecological examination was normal. A complement 3 level was normal, but her C4 level was low. So I guess with this patient, what other things would you want? I guess if you are given this, what's most important in this list? The family history, her lack of clinical response to histamine targeted treatment, a low C4 level, recurring abdominal pain, skin pain symptoms, or all of the above are important in trying to sort this out. All of them. Great. Everybody's way ahead of me here. So additional lab testing, her C1 esterase inhibitor level was low, it was 3, normal being 16 to 33 in this lab. Her C1 inhibitor function using a Quidel ELISA was only 15% of normal, with 68% of normal being normal. And her C4 level was confirmed at 9, again, normal for this lab. And this changes depending on what lab you're using, was also low. So her diagnosis is hereditary angioedema type 1, low C4, low C1 inhibitor, and low C1 function due to C1 inhibitor deficiency. So when you're thinking about treating or evaluating patients that have angioedema, you got to kind of ask some questions. So is this really angioedema? And oftentimes when patients are presenting to your office, whether you're their primary care physician or their consulting allergist or immunologist, they're doing fine. They don't have the hives, they don't have the swelling, they don't have the belly pain when you're seeing them in the office. So photographs are often very helpful. And now that everybody has a camera in their pocket, that's something that's very easy for patients to do. And we certainly recommend that when we see them. Show me the pictures, because everybody wants to show you the picture of their swollen face or their swollen foot. So photographs are valuable. Is it episodic, or is it there all the time? Is it just bilateral lower leg edema that they're thinking may be some type of an allergic reaction? When they say they're having airway symptoms, my throat is closing, I'm choking, there's obviously a differential there. And you have to think about vocal cord dysfunction. You've got to think about tracheal malacia. You've got to think about exercise-induced asthma as other possible explanations for this symptom that the patient has. And the abdominal pain is also hard, because there's a whole list of stuff that can cause the same kind of spasmodic abdominal pain that these patients experience, often with bloating and other symptoms. Appendicitis, obviously, a food allergy didn't happen to Joe, irritable bowel syndrome that her mother and grandmother were told they had, esophagitis, gastritis, et cetera, et cetera. So there's a laundry list of things that you need to go through and sort of rule out before you can move on and saying this is all because of angioedema. So what is angioedema? It's sort of a non-pitting swelling. It's localized, usually asymmetric, and it's due to a result of sort of fluid leak from vessels into the deeper tissues. It typically has a relatively rapid onset, sort of from minutes to hours as opposed to days or weeks. Patients are often normal or usually are normal in between events. And again, the distribution is not in dependent areas. You can see the ladies with her lip and face swelling, and then another woman with fairly severe tongue swelling. So what kinds of things do you want to think about? We talked about allergic reactions. Peggy told us about the food allergy, but it can happen in anaphylactic reactions caused by drugs or insect stings. Radio contrast medium, when we used to use the ionized form, could cause urticaria and angioedema. Certainly aspirin and the non-steroidals. There's a variety of autoimmune diseases can be associated with urticaria or angioedema. And I think we all know about ACE inhibitor-induced disease, which, by the way, is the #1 cause for presentation in the emergency room with angioedema today, is ACE-induced disease. On the other side of the slide are rarer diseases, and we're going to talk about one of them today, but those associated with C1 inhibitor deficiency, both hereditary and type 1 and type 2, which have to do with deficiency of C1 inhibitor from a genetic standpoint, and then acquired, where the C1 inhibitor is actually being consumed by an antibody or being consumed in another way by a tumor or something. And then there are the idiopathic forms that we just can't figure out. And that falls both into the mast cell mediated histamine related diseases as well as the bradykinin induced diseases. We're going to focus on the latter. So what are the medications that you need to be asking about? Again, non-steroidals, certainly ACE inhibitors, certainly the new neprilysin inhibitors that's in the black box warning with angioedema. Angiotensin receptor blockers are reported to cause angioedema, but I'm not convinced that that's the case. I really don't think that that's, I think what happens is people are on ACE inhibitors, they have a swell, they're then switched to ARBs, they have another swell that's probably still related to the ACE inhibitor. And there's been case reports of up to 6 months after discontinuing an ACE inhibitor of patients continuing to have angioedema that wasn't explained in any other way. Certainly the opioids can cause direct mast cell release and urticaria, angioedema, and itch. You know about the antibiotics, and we'll talk about estrogens. On this side are all the other, not all the other things, but many other things that have been implicated, but aren't nearly as common as those on the left side of your screen. So some things to think about. Do you need to do all this stuff? No, you need to take a history first. And wherever your history takes you, then you may want to look into some of these other things as a potential explanation for what might be going on. We typically will get a CBC. We may, if somebody has urticaria, we may get thyroid function and autoantibodies. If we're thinking about acquired angioedema, we may get an SPEP. We may do an evaluation for allergies of various types, and we may do some complement studies as well. But again, it depends on the history. If somebody presents with urticaria and angioedema running down complement studies doesn't make a lot of sense. It's just a waste of time and money. If somebody is, well, we'll go on to that. So let's look at the different sort of mediator split, if you will, here. On the left side are mast cell mediated, whether it's histamine or other mediators that are coming out of mast cells when they're triggered, and they're listed there for you. Histamine, the leukotrienes, which we talked about earlier, prostaglandin D2, and heparin. And most of the mast cell mediated angioedema is associated with urticaria. And that's a good history point. If you're talking to somebody and they're talking about their swells, if they have hives with them, the likelihood is that they are probably driven by a mast cell mediated mechanism. And you can see in the little kid's picture with his swollen face, but he also has hives on his chest and on his shoulders. Then the other mediator, which isn't as common, is bradykinin mediated due to dysregulation of the kinin contact system. These folks don't have urticaria or colitis. They may have some burning and pain if they're having a skin swell, but they typically don't. So that's an important historical point. This is probably, if you're going to take anything away from this lecture today, is probably the most important slide, because it allows you just by history to differentiate between these two types of angioedema and the two types of mediators that are present. So patients that are having an allergic reaction with mast cell mediator releases, the onset is rapid. It happens right now. I mean, you may have witnessed that in the hospital, certainly in the allergy clinic. If you give somebody a shot or do a skin test and they react to it, it happens right now. It's within 15 to 30 minutes of the exposure, whether it's a food or a drug or something like that. Where bradykinin mediated disease is much slower in onset. It may take 12 hours or even 24 hours to reach a peak. And the offset is much slower, 2 to 5 days, compared to a couple of hours after treatment with a mast cell mediated disease. So that's another piece of history. No hives and the rapidity of onset and offset of the disease. And then the third piece here is the response to therapy for mast cell disease. Bradykinin disease does not respond to epinephrine. It doesn't respond to antihistamines, doesn't respond to steroids. And again, that's something that you can ask your patient. Hey, what happened when you went to the emergency room? Well, they gave me epinephrine. So they don't do much anymore, but they gave me IV Tagamet and a steroid shot, and I didn't get any better. And every time I go, I tell them it doesn't work, and they give it to me anyway. But that's sort of the third piece that you can get from this history is, do you have hives? How quickly does it come on? And what happens when they treat you? And what do they treat you with? And if the answer is I don't have hives, it comes on slowly, it lasts for several days, I don't respond to epinephrine, then you need to think about the bradykinin mediated pathway as an explanation. Now, how common is this? This is a series of I think 770 some odd patients from Marco Ciccardi's group in Milan. And they looked at, there were a tertiary or even a fourth level referral center for urticaria and angioedema in Italy. And they looked at patients that had sort of been through the system who presented with angioedema without hives, without wheals. And if you look, so they found a group, maybe 20% of them that had a specific factor that they could find. Some patients even were still on ACE inhibitors, even though they were being referred for angioedema. Others, autoimmune disease or infections were also found. But if you look down here in this group, the C1 inhibitor deficiency, of the 776 patients, 197 of them had this rare disease that we're going to talk about. So almost a third of the patients that walked in the door that were having angioedema without hives had this rare disease. So it's not that rare once you see somebody who comes in and says, this is what I'm having. I'm having basal swells, I'm having hand swells, my belly swells up, but I don't have hives. The 197 includes hereditary and acquired, and then below that are the sort of unknown or idiopathic etiologies, and many of those are also driven by bradykinin. There's some that are mast cell driven, and that the cause can't be found, but some of them, and quite a few of them probably are related to a non-histaminergic mediator. So not that rare. We're going to go way back, 1888. This is a picture of Sir William Osler. He wrote this text in 1892. He was 42. I'm still working on my textbook of medicine. This sucker is 1,200 pages long. You should look at it. You can read the whole text on Google. It's incredible. What I want to show you about this, though, is he was the guy in the U.S. that described this. Quincke had described uvular swelling as an entity in 1882, but Osler made this observation in 1888. And if you look at that, I think you can read it. He talks about angioneurotic edema. He gives Quincke credit for identifying it, if you will, but it's a localized edematous swelling, more or less limited in extent, so in an area of transient duration. Severe colic is sometimes associated with the outbreak. The edema appears suddenly and is usually circumscribed. The back of the hands, the legs, and the throat may be attacked. There's a remarkable periodicity of the outbreak of the edema, and the disease may be hereditary through many generations. He described what we're going to be talking about today perfectly just by observing a couple of families in Canada and also in the Baltimore, Washington area when he was at Hopkins. It took from 1888 to 1963 before we understood that the problem was a deficiency in C1 inhibitor. Virginia Donaldson up at Cincinnati made that observation. Angioneurotic edema. You want to guess what chapter of this textbook this disease was in? Oh, come on. Neuro, perfect. Yeah. So it was one of the last diseases in his neurology chapter. Quincke had described this swelling that he had as a vascular neurosis. And because Osler took that and also heard from his patients that things like stress seemed to make these swelling attacks occur, he figured it was something to do with neurosis and therefore called it hereditary angioneurotic edema. That stuck until the mid-80s. So this is a busy slide, but I'm just going to tell you everything about this disease in a slide. So what we're going to be talking about today is HAE with C1 inhibitor deficiency or dysfunction. I'm not going to talk about HAE with other stuff. It's called HAE normal. Come to allergy grand rounds after this, we're going to talk about it there. It's caused by a deficiency, if you have type 1, or dysfunction type 2 of C1 esterase inhibitor, with a dysregulation of the contact or kinin pathway. It results in increased bradykinin production. Bradykinin causes vasodilation, vascular leak, and swelling. The prevalence is difficult to determine because of underdiagnosis, underrecognition, but it's probably somewhere around 101 per 67,000 people in the world. 67,000. In the United States, we say 1 to 50,000. In Europe, it's 80 to 100,000, depending on what country you look in. There's no ethnic or gender differences. This is an autosomal dominantly transmitted disease. So it's a 50-50 disease between men and women, although women tend to be more severely affected than men, but equal chance of transmission. It's angioedema without urticaria. The average attack frequency is about twice a month in these individuals. And what's interesting is the disease severity is quite variable, not only through the life of a single patient, but also in a family that may have the same mutation, where one individual may be severely affected, disabled by the disease, and the other not even bothered particularly by it at all. So why should I care? I mean, you all are here, and I appreciate that, to hear about this. But if this is only going to, if I'm going to look for this all my lifetime and never find one, why should I really worry about this? And that's kind of what I thought at Scripps when we saw a HAE patient and was working with her. It touches all of us. I mean, if you're in family practice or internal medicine, or pediatrics, you're going to see these patients, because you're the first point of contact. Ditto with the emergency room. Obviously, allergy immunology sees it. Cardiology may see it associated with ACE inhibitors. The gastroenterologists are going to see it because of the recurring belly pain that's not explained. Infectious disease may come on board, nephrology, the whole deal, oncology with acquired angioedema. These people have significant psychological issues. In fact, the incidence of depression is about twice as much in these folks as in the normal population. And so the psychiatrists and psychologists get involved. In fact, a lot of these patients, before we had people, a little information about this disease in the medical world, they were just sent home as either drug seeking because they go to the emergency room with belly pain and want opioids for it, or they were just crazy. Couldn't find anything wrong with them. So they were just crazy. And because of that, this population has a very lack of respect for sort of our medical profession. Anesthesiologists, trauma to the throat, swelling, ditto or laryngology, general surgery, anything that might cause trauma to the body, a dentist pulling a tooth. And if you don't think or know about this disease, obviously you can't recognize it in diagnosis. So what swells? The skin and the belly. Primarily, about 46% of all attacks are skin attacks, hands, feet, face. About 42% are belly attacks, where patients get essentially an obstruction of their bowel. They get such edema of their bowel wall that the bowel obstructs, and they present with symptoms of an acute or surgical abdomen. The next, but fortunately less frequent, is laryngeal or airway attacks. About 50 to 60% of patients with HAE will have a laryngeal attack at some time in their lifetime. But fortunately, it's not as common. The uvula can swell, the tongue can swell, brain and bladder may be able to swell. This is a picture of erythema marginatum. It's seen in several different diseases, and HAE with C1 inhibitor is one of them. I show this because if somebody comes in and you ask them if they have had a rash or hives with their swelling, they may say yes, and this may well be confused with urticaria. And you go down a different rabbit hole and not think about, you're talking about our history of being able to differentiate. This is a serpiginous rash. It's not raised, it's flat. It doesn't itch, it's effervescent, it just kind of comes and goes. It's a prodrome in about 50% of patients before they have an attack. But again, it doesn't itch. So that's a question that you have to ask if somebody does have an erythema marginatum. So this is a hand swell. 95% of patients have this. It can be functionally disabling. People obviously don't die of this, but they can't drive, they can't type, they can't use their phone. If their feet are swelling, they can't walk and stand. And it interferes with work and school, but rarely results in any type of hospitalization or in the past, any type of treatment. This is abdominal attacks. This is a picture of a CT scan just showing an area of swollen bowel and maybe some dilated loops of bowel looping up. You can't really see that very well on this CT scan. These folks have commode hugging pain. I mean, lay on the bathroom floor in a fetal position, trying to get over the pain because they have this bowel obstruction and they have this repeated episodes of spastic pain with often vomiting and nausea, occasionally diarrhea. They often will swell. I didn't bring that picture, but picture women that look like they're 9 months pregnant and they start bloating up. And oftentimes these things look like a surgical abdomen. And in the past, before we had CT scans and other things to really explore the belly without opening it, about 25% patients had either exploratory laparotomies or appendectomies as a result of the attack. What I want to show you here, this is actually a capsule camera picture. This is again is from Marco Ciccardi's group. Up here at the top is a patient that presented with an abdominal attack. And you can see the swollen mucosa. You can see that the lumen is blocked. If you look at the time here, this is 3:17 in the morning. These attacks always occur in the middle of the night, right? When you get the phone call. The patient was then treated with encalantide, a plasma kallikrein inhibitor that blocks bradykinin production. And within an hour. Now it's 4 o'clock, 4:11 in the morning. You can see sort of a normal folding of the ileum. The swelling is down, and the bowel is starting to open and fecal material flowing again. So a really interesting, I guess, observation that group made of this. Laryngeal attacks, again, occur in 50, I think probably more percent of patients. They require obviously aggressive airway monitoring and management. It's sort of one of those things, if you think about traching, these folks should do. Conrad Bork surveyed 58 patients over several generations of German patients, and he found that there was a 40% incidence of death due to asphyxiation when someone had a laryngeal attack and wasn't treated appropriately. You can see, and this is actually a young patient of mine. She was 6 years old when these films were made. She presented to the emergency department saying that she couldn't swallow and she was drooling. And the physician said he thought she was just malingering, couldn't see anything in her mouth. Sent her up to the radiology department where this film was on your left side was obtained. And you can see that she straightened out her neck to be able to get an airway here. The epiglottis is hugely swollen, as is the back of the throat. And she has just very little airway here. Needless to say, the radiologist freaked when he saw this film and personally escorted this child back to the emergency department. We were doing a trial with a C1 inhibitor with her mother at that time, and she had that, and we were able to treat her, and she didn't require intubation or hospitalization. This is her 3 weeks later, and she's not swelling. You can see all the structures are normal now. Normal curve, the epiglottis isn't swollen. She's got a normal airway here. But these are the things that these patients are afraid of. This is what's going to kill them. And before we had good treatment, often it did. So when do you consider the diagnosis of hereditary angioedema? Family history of swelling, family history of choking or throat swelling, or as a cause of sudden death. Or if they have episodes of angioedema without urticaria, unexplained belly pain, and then to make a diagnosis, you've got to find a low C1 inhibitor antigenic or functional level. 95% of them have a low C4 level, which is the test that we recommend be obtained as a screening test. 95% of the time, this is low, even when patients are not swelling. So it's a cheap test, easily obtainable. The ER won't do it because it can't get it stat, and they don't want to follow it up the next day. But I wish we had a way to do that. So let's talk a little bit about the pathophysiology of this disease. What's going on? So it's complicated. This shows basically the three pathways where C1 inhibitor is a regulator. We're going to focus on the one in the middle, but it's important in regulating signals from the fibrinolytic pathway by blocking plasmin effects on factor 12. It's important, and that's where it got its name, in regulating activated C1 on your left side over there. But again, in the middle is what we're going to talk about. And what basically happens is factor 12 gets activated in the absence of C1 inhibitor. That allows high molecular weight kininogen or prekallikrein to be activated to kallikrein, which cuts high molecular weight kininogen and releases bradykinin, which then causes, through the bradykinin 2 receptor, vascular leak and localized edema. So to make it a little bit maybe simpler to look at, this is the same pathway, and I've also included the C1 or the classic complement pathway below that. And again, you can see if they're up at the top, if there's something that triggers that factor 12 to activate, and it's always activating, but slowly and controlled by C1 inhibitor. So stress can do it, trauma can do it, other things that we don't know about can do it. Once factor 12A is made, it feeds back onto factor 12 and activates more factor 12A. So there's a sort of an exponential increase in factor 12A. Then it interacts with prekallikrein, which turns into kallikrein, which then cleaves high molecular weight kininogen to release bradykinin. So how did this protease get called C1 inhibitor, and why is C4 low in this disease? Well, down here at the bottom, you can see that once that pathway up there is activated, activated factor 12A goes to factor 12F, and that can trigger the classic complement pathway, which, if not inhibited by C1 inhibitor, causes C4 and C2 to be digested. So both of those levels go down in patients that are lacking C1 inhibitor. So what happens then is just simply this, that bradykinin is produced, and that then causes interaction with the receptors on the vascular endothelium and swelling. So these are the complement studies that you might look at in patients that have recurrent angioedema, again, without wheels. So across the top, you can see C1 inhibitor level, C1 inhibitor function, a C4, C3, and a C1q. In type 1 HAE, they don't make enough C1 inhibitor. So their mutation doesn't allow them to make it. The protein doesn't fold upright, so it doesn't get out of the cell. So you can't measure it in adequate levels. And because of that, they have low function. And because they've got this lack of control of C1, the complement pathway, their C4 level is usually low. In type 2, they make a protein, and you can measure it, and it's often normal or high, but it doesn't work. So in type 2, you've got a normal C1 inhibitor antigenic level, but you've got a low functional level. And because it doesn't function, you've got a low C4 level. Another disease that looks like this from a laboratory standpoint is down here at the bottom. Acquired, well, I showed that. I showed that. So is the acquired C1 inhibitor. It looks exactly like type 1. There's a low C1 inhibitor level, low C1 function level, and a low C4 level. But in 70% of patients, they also have a low C1q level. And again, that can be driven by an antibody reaction against C1 inhibitor or consumption of C1 inhibitor by a tumor surface or some other autoimmune mechanism. Below that, ACE inhibitor looks like the C1 inhibitor disease as far as the phenotype, but all the lab is normal, and idiopathic angioedema is also normal. Again, we're not going to talk about HAE with normal C1 inhibitor, but obviously it's normal too. But that's why with those tests, the C1 inhibitor, C1 functioning, C4 level, are the ones you need to get. To begin with, if you're seeing somebody whose disease is presenting in their 40s or 50s, C1q should be obtained to look for acquired C1 inhibitor deficiency. Most of these folks have onset of disease in childhood, 50% before the age of 10, about 100% by the time they're 25. So if you're seeing somebody that's just showing up with this kind of lab and presentation in their 40s or not. So this is a WAO sort of guideline. This will be on the slide set, so you can do it. But if you can follow this along, if you suspect HAE, get those levels. If it's normal, well, you can follow the pathways ways down. I'm not going to go through that. One hint here is if you're getting normal levels when the patient is asymptomatic, if you can repeat a blood test, particularly get a C4 level during an attack, it's almost 100% going to be low in this disease. So if you've got conflicting data, say a low C1 inhibitor or marginal C1 inhibitor function or level, and a normal C4, but you really think the patient has the disease, if you can get lab during an attack, it may prove to be helpful. So let's talk about treatment. There wasn't any until 1960-ish when the folks, Dr. Land and Virginia Donaldson, figured out that androgenic steroids somehow worked to make this disease better. And testosterone was the drug available at that time. The attenuated androgens weren't available. They also figured out that FFP, which contains C1 inhibitor, there's 1 unit of C1 inhibitor per cc of fresh frozen plasma, could also be given to these people and stop attacks. The things in yellow are the things that we use for treating an attack when they occur, or on-demand therapy. The ones that are in white are those that are used for prophylaxis. We also figured out in 72 that the antifibrinolytics like epsilon aminoproic acid or tranexamic acid helped some of these folks. And then danazol, a better androgen than testosterone, if you will, was introduced in 1976. In Germany, a C1 inhibitor was purified and began being used then. Actually, Mike Frank used it in studies at the NIH in 1976. But you know what happened in 1980? AIDS came around, right? So all plasma drug development stopped for about 20 years. So it really wasn't until 2008 that the United States had an HAE-specific drug approved. And that drug was a plasma-derived C1 inhibitor for prophylaxis, not for on-demand therapy. A couple of years later, we developed both an IV C1 inhibitor for on-demand therapy, a kallikrein inhibitor, and a bradykinin 2 receptor antagonist, and then later than that, a recombinant C1 inhibitor, all given either subQ or IV. And then in the last few years, we've learned that subcutaneous C1 inhibitor works very well for prophylaxis. I'll show you that data. A monoclonal antibody that blocks kallikrein, lanadelumab, and then more recently, oral plasma kallikrein inhibitors. So if you look at this, it's an interesting timeline. What's even crazier is if you count this, as of today, we have 8 FDA-approved drugs for the treatment of this disease that affects about 6,000 people in the United States. There's 7,000 orphan diseases in the United States. To be an orphan disease, you have to have less than 200,000 people in the United States to be called an orphan disease. There's about 7,000 of them, and most of them have no treatment at all. This one has got 8 and soon to be 12. It's great. It's easy because the targets are there. So what are our goals of therapy? Obviously, stop attacks when they occur. So we call that on-demand treatment. We know that certain events like medical surgical procedure, stress, et cetera, may cause an attack. So using a short-term prophylactic program during those events, and then long-term prophylaxis to try to decrease the overall severity of the angioedema attacks. And then obviously that all has to be worked out with the patient in an individualized management plan and shared decision-making as well. So there, I'm going to even make our little graph, our little flow sheet easier. But if you look at this, you can see where you might attack this. So could you do something up here and block the activation of factor 12? Could you block the effects of activated factor 12, this feedback loop here? Could you do something to prekallikrein? Could you do something to kallikrein itself? Could you, so that it doesn't make bradykinin, can you do something to the bradykinin receptor antagonist to prevent angioedema from occurring? And the answer is you can do all of that, and we've done all of that. There's a drug for each one of those. These are the on-demand therapies that I showed you on that timeline. The blue is C1 inhibitor. So somebody's having an attack, you infuse them with C1 inhibitor, it shuts down the pathway, the attack stops. In red is encalantide, which is a plasma kallikrein inhibitor. So it blocks the production of bradykinin. Again, the attack stops. It's given subcutaneously. And then last, icatibant, which is a bradykinin 2 receptor antagonist, kind of like an antihistamine for the bradykinin receptor, that blocks the effects of bradykinin on the vascular endothelium. So you stop the swelling. So what's the data that backs all this up? This is from Conrad Bork group in Mainz, showing that C1 inhibitors knocks down an attack, whether it's laryngeal or abdominal, within 30 minutes. You can see across the board there, the red is the laryngeal attack and the blue is an abdominal attack. Been multiple studies showing this is efficacious. It's been around in Germany since the 70s, as I mentioned, and virtually 100% of patients with type 1 or type 2 will respond to this. The approved dose in the United States is weight-based. It's 20 international units per kilogram. So somewhere between 1,000 to 2,000 international units for an average adult patient. It's approved down to age 6, but can be given really younger than that if you can get an IV in the child. This is the recombinant C1 inhibitor made by rabbits in the Netherlands in Leiden. And it is, yeah. And you can see compared to the two doses in blue and green compared to the red saline placebo, again, the decrease in the visual analog scale, which is skin pain, skin swelling, and abdominal pain, drops off very quickly once the patient is treated. So not a plasma-derived product, infinitely available because of the method of production. This is the data on encalantide. Again, it's a subcutaneous dosage. This is data from their phase 3 edema trials. You can see in these two bar graphs, the orange is encalantide, the gray is placebo, and these are different scales. The mean treatment outcome score, the higher it is, the better. The mean symptom severity score, the lower it is, the better. And you can see at 4 hours, both of those scores are significantly better than placebo. It's approved for age 12 and up, but the challenge with this drug is there's about a 3% incidence of anaphylaxis when it's given. And so it's not really approved for self-administration, which is a pain because the patients need to be able to treat themselves when they're having an attack. They don't need to go to the clinic or whatever. So it's not been adopted very widely because of that problem, but it works very well. It also proved the concept that if you block plasma kallikrein, you can stop hereditary angioedema. This is a Catavance that says we did along with these other ones. And it looked, this is a subcutaneous injection. This is phase 3 trial data. Injection site reactions were the most common adverse event. The challenge with this drug is it's not approved below the age of 18. So little kids, at least in the US, can't get it. It's approved down to age 2 in Europe. But you can see, if you look over far to the right, you look at almost complete relief of symptoms. It's about 10 hours for patients that were treated versus 40 hours in patients that were on placebo, and a 50% reduction of symptoms occurred within 2 hours with treatment versus 20 hours with the placebo-treated folks. We recommend that all attacks be treated. Some patients choose not to treat the quote milder attacks, but we recommend that patients have 2 doses at any time to treat an attack, and sometimes they need to repeat, particularly with a Catavant. We know that the earlier you treat, the less swelling there's going to be, so there's less morbidity, there's less long-lastingness, if you will, of the attack. And if somebody's having a laryngeal attack, we recommend that they treat it, but then go to the hospital in case it's not responding to the therapy. And that's one, just for a second. Sorry. We know this also improves patients' quality of life. This was a study we did with HAEA patients in one of their national summits. And this was asked the question, has the burden of this disease changed since you've had access to on-demand therapy? And you can see whether their severity was none, mild, moderate, or severe, that the patients that just almost with every category, whether it's psychological, whether it's daily symptoms, whether it's suffocation, fear, whether it's side effects, those all went down, particularly in the moderate to severely affected patients. The one that didn't change was obviously the effect on their children, the concern that they're passing on this genetic disease to their child, and having a treatment for it didn't necessarily relieve that guilt, if you will. So short-term prophylaxis, what do we use? We use it for oral and any kind of dental trauma, so intubation, major surgical procedures, or any other invasive procedures that might affect particularly the airway. The current recommendation is to use C1 inhibitor concentrate, to give them an infusion of C1 inhibitor, bump their levels up before the procedure, and then observe them closely afterwards with a plan to use on-demand therapy if need be. So this is where you may get involved if you're in other specialties seeing one of these patients and you need to do a procedure on them. You need to make sure that you've got them covered, that they're not going to have an attack during or after the procedure is performed. Your allergy group can help you with that. So what do we got for long-term prophylaxis? A little different looking slide, but we have C1 inhibitor. You can pump up C1 inhibitor by giving androgens like we did back in the early days. That's no longer a recommended therapy, but it works. We can use plasma-derived or recombinant C1 inhibitor on a regular basis to keep the level up and prevent attacks. We have a monoclonal antibody, lanadelumab, that blocks plasma kallikrein. And then more recently, we have an oral plasma kallikrein antibody, plasma kallikrein inhibitor, Oroltostat, that also does that with a once daily pill. This is androgen work. It works well. You can see 91 to 100% attack reduction in 80% of the patients in this study by Conrad Vork. The problem was that 58 of the 120 patients in the study had to stop because of side effects. What kind of side effects do you get with androgens? Well, you know what they are. You get changes in lipid profile, you get changes in the liver, anywhere from cysts to carcinoma. So if patients are on androgens, they need to be monitored for liver issues as well as cholesterol, lipid issues. This is data from the first C1 inhibitor IV trial. Patients were giving themselves an IV of C1 inhibitor every 3 to 4 days. And you can see that this was a crossover trial. So when they were on placebo, you can see the attack rate versus when they were on C1 inhibitor. And there was about a 50% decrease in attack frequency at the 100 unit every 3 to 4 days dosage. We found that if you push that dosage up, you can get a much better response. This is not used much anymore because of the issue of having to go do an IV every 3 to 4 days. And patients did it if they had bad disease, but their veins wore out, they got tired of it, et cetera. If they went out and got a port put in, they get infected or clotted, and it was a big mess. So we learned from the IVIG to sub-Q IG experience that you could give these things subcutaneously, get a steady level, and not have to worry about giving an IV, which is what happened with this drug. This is the subcutaneous plasma-derived C1 inhibitor study, compact. And we found that at a dose of 60 units per kilogram twice weekly, we could achieve a 95% reduction in attack frequency. Basically taking people who were having 3 to 4 attacks a month to maybe 1 attack a year. Safe from an adverse event standpoint, again, approved and usable in individuals age 6 and above. And you can see that, again, the results were quite nice with that. What about the monoclonal antibody? This is a plasma kallikrein inhibitor called anadelumab. In its phase 3 trial, at a dose of 300 milligrams every 2 weeks, subcutaneous, we could reduce attacks by 87%. So that bar is, way up there. And again, you can see the responder rate at the different doses. The initial dose is 300 every 2 weeks. They can go to every 4 weeks if they're attack free for 6 months or more. This is approved down to age 12, soon probably to age 5 and maybe even younger. This is the oral plasma kallikrein inhibitor. Didn't work quite as well. There was only, if you look up here, there was only a difference between placebo attack frequency and 300 or 150 milligrams daily of about 43%. So not anywhere close to the other two. But the responder analysis was pretty good, that 50% of the patients actually had a 70% or more decrease in their attack frequency. And they didn't have to give themselves a shot, they give themselves an IV, they could take a pill every day. There is some side effects associated with this, belly pain primarily, some other GI symptoms, including GERD, vomiting, and diarrhea. What about quality of life improvement with prophylactic therapy? It's great. This is looking at what's called the AE-QoL, Angioedema Quality of Life Survey, and you can see the different levels: functioning, fatigue, fear, shame, nutrition. And in the blue and black compared to the gray, you can see with each domain there was a significant improvement in quality of life when patients were on this. This is the monoclonal antibody trial. So what about new therapies to decrease the attack burden, less frequent, maybe not sub-Q, et cetera? What are we looking at? And just to kind of go through this because it's not out there yet, but it's coming. The yellow is, again, acute therapy. We've got an oral on-demand drug, KVD900, plasma kallikrein inhibitor. We've got an oral bradykinin 2 receptor antagonist, the Pharvaris 416 drug, which are both in phase 3 trial or will be soon. Pharvaris is not quite. And in the prophylactic world, we've got a whole bunch of stuff. We've got an mRNA antisense prekallikrein inhibitor, this Ionis PKK IRX. We've got a very long-acting monoclonal antibody. You can mess with the FC. I'm not a chemist, so but apparently you can modify the FC receptor on these antibodies and make them last much longer. And this STAR 0215 may be a once every 6 month subcutaneous therapy that blocks plasma kallikrein. The closest one to being approved is CSL 312 or garadacimab, which is a factor 12A antagonist. And then probably most interestingly, even though we've got all these great drugs, gene therapy is entering this field as well. Jim Widmer has dosed a couple of patients using an adenovirus vector induction of C1 inhibitor into hepatocytes. And then there's a trial that uses CRISPR-Cas9 to edit the prekallikrein gene to knock out prekallikrein so that the pathway doesn't have the juice to go, if you will. And those results, initial results, were reported just a couple of weeks ago at the college meeting, and they seem to be very, very promising. So we've got a whole bunch of drugs, again, coming down the pipe for the treatment of this disease, again, to try to lower the burden of treatment, or maybe even cure the disease in the case of the gene therapies. So this is sort of from the college, the podium to practice takeaways from this morning is where most cases of angioedema are mast cell mediated. HAE is mediated through bradykinin. Type 1 and type 2 result in a deficiency or of C1 inhibitor function. You can diagnose it very easily with tests that are readily available and repeatable. Most treatments are aimed at blocking bradykinin production, either by knocking out the bradykinin receptor, blocking its effect, which obviously reduces the swelling. The guidelines, and I didn't show you that slide, but there's a variety of very good guidelines as far as how you think about these patients are out there, looking at both the management of acute as well as short-term as well as long-term prophylaxis. You know, treatment of these orphan diseases, particularly this one, obviously improves patients' lives and also saves lives. And lastly, it's kind of one of those things, if you don't think about it, you'll never diagnose it. So with that, I'll say thank you and be happy to answer any questions. We're right on the hour, so appreciate your time.
Thank you so much for that. We have questions for Dr. Lumry.
From a non-allergist. So why is there such incredible diversity for people who have basically the same mutation?
I don't know that. I don't think we understand that. In fact, there's been several, there's about almost 400 different mutations now that are reported for HAE type 1, type 2. There have been some studies of identical twins, obviously same mutation, same family, same housing situation, et cetera, where one of the girls was essentially disabled by her disease, couldn't leave the house, and the other one functioned in society, went to school, had a job, et cetera, et cetera. And there's not, we don't understand that. It's sort of like, how does stress cause this system to fire off? There's some thoughts about that, heat shock protein, et cetera. Alan Kaplan's done some work, but we don't really understand why some individuals, again, with the same mutation, are affected so differently. Also, we have some understanding of why through life it may change. So it tends to get worse around puberty, particularly in women. When estrogen levels go up, estrogen tends to make this disease worse. We know it may get better through adult life. It gets worse with pregnancy again. It may get better at the end of life, but may not. So we don't really have a good understanding of that yet. But it's interesting that you think it's the same mutation, it ought to work the same way. That should be the same as snow. It's good. Thanks.
Comment, I guess, because of that
Okay. So the question is, what about using these drugs for ACE-induced swelling? I will say that it works. Icatibant is a bradykinin receptor antagonist. The trials that have been designed and both, well, there was a trial that was actually done here at WashU, looking in the emergency room if patients came in, treated, and the primary outcome was whether you were hospitalized or put in the ICU or not. And the answer was that it didn't seem to make a difference. And it may well be that because patients, this is ACE inhibitor angioedema is not something they've had before. It shows up one day and their tongue swells out of their mouth, like the picture I showed you. And they come to the emergency room once all that swelling is there. And then all we can do is stop the progression of the swelling. We can't make the swelling go away. And so oftentimes patients, if they come in with a tongue that looks like that, even though they're breathing well, you're not going to send them home, even if you treated them. And I think that sort of design flaw in the study showed that it doesn't, there's no reason that it shouldn't work. If you could, you can show that if you take these patients, block the bradykinin receptor and give them, make them have an attack, they don't have an attack. So the mechanism is the same through the bradykinin pathway, but we just haven't been able to design a study to do it. And again, there's often a delay in treatment. Emergency rooms don't necessarily have a CAT event to give these patients when they come in. But certainly if you've got somebody who is swelling, you're trying to keep them from being intubated, and you have access to a CAT event, I would use it in that setting. Just like if somebody comes in with angioedema and you don't know what it's coming from, you're probably going to give them steroids and antihistamines and epinephrine anyway, until you know what your diagnosis is. But if it's pretty clear that it's ACE inhibitor, that CAT event is probably the way to go.
All right, we're running a little late. We're a little past 9. So
Perfect.
thank you so much for coming.
Pleasure.